Thank you. I thought maybe I needed to add a little bit of history. Dr. Gail Christopher had a wonderful video of the history of breastfeeding in this country, but it didn't start at the beginning. Actually, back in 1940 and 1950, there was a physician, Dr. Edith Jackson, at Yale University. She was a self-made, she was a pediatrician and a self-made psychiatrist. And she decided that childbirth and everything else had gotten a bit out of hand. And she started the program, the first rooming in program. She went to England and studied with Grantley Dick Reed and learned about childbirth without fear and realized that women had to understand the childbirth process so they could participate instead of fight childbirth. She developed the first rooming in, after which all others are patterned. And this was in 1940. She had federal grants to do this, and everybody breastfed. And so this was somewhat ignored. I had the good fortune to train at Yale before Edie retired. And when I came back to Rochester and went to my clinics, all the clinic mothers were breastfeeding. All of the African American mothers were breastfeeding. And I would say to them, "Oh, how do you do that?" And they'd look at me like I was some stupid doctor and say, "Well, you just put the baby there." And so it was these wonderful mothers who kept breastfeeding alive in this country until the history was picked up in the 70s. And by that time, the formula companies had gotten to these wonderful women. They too were consumed by the benefit of letting science feed their babies. And so it was the well-educated mother who seemed to lead the march back to the breast. But we cannot forget these wonderful women who kept on breastfeeding when it wasn't the thing to do. So on that note, I would ask our speakers to respond to questions. And Susan, Dr. Haynes, please take the mic.
I'm Susan Haynes from the Office on Women's Health at HHS. And Dr. Askew, I enjoyed your talk very much. And I have a couple of questions for you. The first one is, do you know the rates of breastfeeding in the Early Health Start program? I know we worked with them years ago to try to get that policy enforced because that was sort of being ignored. And I know there was a lot of work by their leadership to increase it. Do you know what the rates of breastfeeding are in that group?
No, actually, I don't know. Is this,
okay.
Is this on? I don't know the exact rate of breastfeeding.
It might be really important for you to ask them. Just just the fact that you would be asking might actually reinforce its importance. Yeah. And the second question I have is, ACF, I think, is involved in the Welfare to Work program. And when that was first put into the action, I remember talking to Dr. Shalala's assistant, Sarah Kovner. I said, what is that going to do to breastfeeding rates and those moms who were forced to go back to work in the Welfare to Work program? And she said, well, we can't really deal with it right now. We'll deal with it later. So I don't know that it's been dealt with because I recently saw a report that the Welfare to Work program has compromised breastfeeding rates, at least among those women. And I didn't know if anything has been done to actually encourage that program to encourage breastfeeding among those moms in the Welfare to Work program. And I think it's at least I saw a report that suggested that most of the states weren't supporting it, and the rates of breastfeeding were low.
What was the report and where did you see it?
It's in my office.
Okay, please, please, since we're on the same email, please send it to me.
Oh, you're on the same email, yeah.
Yeah, if you're at Health and Human Services.
Yes, right.
Yeah, no, send it to me.
So I didn't know if that what was told to me. I called ACF about it, and they actually said, well, you know, it's up to the states.
Who did you speak to?
I don't know.
Okay.
And there was
So-
somebody in that program, and they said, you know, we don't have, ACF have a rule to say that women can breastfeed or give exception to in that program if they're a mom. And so I said, well, who decides? And they said, each state decides by themselves. So one of the things you could do where you sit, if this is still the case, and I think it is, you could suggest a regulation that says that these states who run the welfare to work programs have to accommodate mothers who want to breastfeed.
Yeah. Yeah, please send me the information. I'll see what I can do.
Okay,
Great.
thank you.
Good morning. I'm Cindy Pellegrini from the March of Dimes. And Lakeisha, I think my question is probably a little bit more aimed at you, and it has to do with quality measures. The March of Dimes has done a lot of work around perinatal quality measures and been very involved at the National Quality Forum on more panels and committees and teams and working groups than I care to remember. But the attitude often seems to be different around the breastfeeding measures than around either sort of the more purely medical or the more purely behavioral health ones. And you can talk about tobacco cessation measures, and you can talk about anticipatory guidance type measures and counseling about this or that or the other thing. But somehow when you start talking about the breastfeeding measures, the hospitals in particular, but the plans too, they fling their hands in the air and go, we can't do that. It doesn't make a difference. We don't have an impact. We can't make them breastfeed. And I'm wondering if you've seen the same thing and have any insights into where this is coming from. There really does seem to be a different attitude about the breastfeeding measures, and it feeds a resistance to them.
You know, I think that there's so many other competing priorities that perhaps that's part of it. You know, I haven't necessarily seen the resistance as much from the kinds of entities that you mentioned in terms of, you know, who has the locus of responsibility. I mean, certainly we've had some discussions about, you know, what happens prior to a woman going to give birth and the kinds of things that happen, you know, up until that time in the doctor's office, whether it's the birthing bags or all of that, and not to mention what happens upon delivery in the hospital and getting those kinds of things. You know, I think our efforts have been about changing behaviors generally, and trying to work both sides. We perhaps have not been extremely effective yet with either, particularly around this issue. I think now that we are participating within with the Best Fed Beginnings, and we're participating on federal work group, you know, we can make a little bit more inroads in regard to bringing this issue to the fold. So I know that one of the groups that was mentioned earlier, NICHQ and others, are, you know, this is an area of importance to them, and they're trying to get into the process. So we have, as I mentioned, a vetting process for the quality measures that we use. And it's really about how convincing, you know, we can be, and particularly if you have evidence and data. So, and actually this is something I shared with some other folks somewhere, about using a CMMI as the venue to get things to happen, or to at least to test activities. And I think in terms of uptake there, you have to have the evidence, or some evidence. If you can have evidence about money, what kind of conditions can be impacted by breastfeeding, you know, that helps. But in terms of the measurement, I think we'll see. I think we're evolving in this area, and we'll see what comes in the future with our sets. But as I mentioned, at least we now have something on Hospital Compare, and it's a starting point, you know, certainly. Or we don't have it yet, but it's coming.
I'm Jaretha McKinley with Health Connect One, and pleased to have both of you. Was impressed with both of your presentations. Dr. Askew, I had a question about the additional standards going into discussing in early child care development programs discussing breastfeeding and including it as a measure, will there be additional funding available for them to incorporate breastfeeding? As we do work, Health Connect One does work around the country. Many of the early child development programs, early Head Start programs that we work with, Washington State, Wisconsin, Illinois, Georgia, have a desire to incorporate more breastfeeding support and education with their families, but their concern has been following all the other standards they have to follow with, for instance, early Head Start, and don't have the resources, the education, the professional guidance, and the funding to do that. So,
I guess the simplest answer to that is that the investments that are being made in early childhood, particularly this $500 million that's going to go into expanding early childhood services, is sort of a new source of funding. What's important when that new source of funding gets out into the field is that part of the requirements that we're asking folks to address with this new funding is breastfeeding education and support. So while there's not additional funding specifically aimed at breastfeeding and supporting breastfeeding, the funding that is going out requires that breastfeeding education and support be a part of whatever program you're putting together.
that's important for us.
Yeah.
Thank you.
And stepping up to the mic is Dr. Christopher Wade, whom many of you may recognize, will be the co-chair and be moderating tomorrow. And Dr. Wade has been at previous summits, is a founder of the Academy of Breastfeeding Medicine, and was for many years the secretary treasurer and record keeper, and is an expert in California healthcare, HMOs, and all other good things. So you had a question, Chris.
I do, for Dr. Richardson. Actually, I think many things were brought up around CMS, right? Hospital, JACO, whatever you want to call it for rules-based. And then I come from another part of, even though I'm a preventive medicine specialist, public health person, and breastfeeding specialist, my background is in computer technology, and I also have my degree in computer engineering. And in creating the electronic health record standards, of which the government is using many of the standards, we do have a conundrum between CMI, which is the Care Management Institute and definition of care policy around diagnosis. Then from CMS, who tries very hard to work with CMI to interpret those things and embody a revenue payment reimbursement stream for practitioners and people in healthcare to be able to properly assess the amount of money that gets paid for it. I think that the discrepancy between what CMI calls procedures and defines the documentation that a physician or provider of care needs to provide for that reimbursement rate falls short in, I'm going to call it the home visiting area specifically today, though it falls short in other areas. And do you think that there is, with bringing I call it JACO, into the triangle, that CMI will move off of its position of looking at procedure-based reimbursement, diagnostic categorization, you know what I mean, into the realm of what I call really therapeutic treatment for conditions for breastfeeding and the support of normal breastfeeding in the future?
So this is a tough question for me to
It is.
answer.
I believe it is. I only ask tough ones, but it's okay.
I will say that it's a question that I've heard in other venues. So thinking about contraception, other areas
There's many
in
areas, yes.
particular. I can say that we're working on it, but I don't know that I'm the best to answer that question about merging or bridging the gap between the couple of areas. I don't work on that part specifically, but I have been in consultation with my colleagues because, you know, at these various meetings I attend, whether it's contraception issues or breastfeeding or others, you know, I recognize that there are some limitations within the electronic health record, the fields, the variations even. And so I can't answer about what that timeline will be because I honestly don't know, but I know that it is that it's an area of importance, and it's one that I raise whenever I hear it. You know, I can give another example of where there are some limitations. I think I really need to go back and figure out a little bit more about that process and how we change it. I mean, because certainly we influence it a great deal, but you know.
Well, I think it's, believe it or not, let's come from the payer provider rules that are set up within CMS for reimbursement processes for Medicare, which are a more standardized process versus the ones that Medi-Cal and Medicaid are, you know, each state's process. When I go to CMI and I fight for something that is really, let me just call it, not correctly presented, is that a good way to say? When you talk about evidence-based medicine, I'm talking about real evidence-based medicine, not just some results from some things. Whether the clinical outcome was of the highest quality and standard in that clinical evidence. And I put enough power behind that to change certain things. But there are relationships in CMI that I don't think are investigated well enough to know how they're supporting their decisions at different times. So let me give you an example. So in the Academy of Breastfeeding Medicine, we don't take any kind of supportive processes from any formula-based company. That was sort of like between a moral decision and an absolute that we had to have for the Academy to support breastfeeding medicine. We're not going to take education money, et cetera. We did that same thing with pharmaceutical representatives in the past, and I'm with Kaiser, and we made a moral decision as a medical group to have the health plan not have and allow people across a hospital barrier to present their drug information to doctors. They can gain it through the highest quality of use indicators, et cetera. And I think that in the area of breastfeeding, childhood nutrition support, especially as we move into communities of care, which is, I call it the local area of taking ownership, that you want them to have the highest quality practitioners, people who are serving them, creating, working with them, and that quality outcome is going to be improved. And therefore, it is not going to be only a procedure. You know what I mean? It's not only going to be, I have my 15-minute visit, it's going to be built into a visit mechanism. If I have to go out and see a mom 45 times in the field and get that baby really well established and then she breastfeeds the next 10 kids she has, it's well worth that. But how do we deal with that? So that's where I'm really coming from. I think we can be effective. You're in a position, I call it the triangle. I really feel for you in that triangle with trying to get equanimity between three agencies that haven't really talked in the way that I'm talking right now yet. So, but I really I respect what you do on that side and trying to deal with them. It's got to be very difficult at different times. Thank you.
Dr. Bartek, are you heading toward the mic?
No, I'm just stretching.
Oh, you're high. Well, I saw you back there with your calculator. I was imagining you were trying to figure out how much all this was costing. But we'll hear from Dr. Robert Lawrence.
I wanted to ask a question. You mentioned the core measure sets, and you said there was an established process. And I was wondering if you would take a few minutes to tell us what that established process was, in part because it may help us provide you with additional information or other programs or ideas that might be useful.
Sure. So are you familiar with the NQF process in general for measurement?
Vaguely, yes.
Okay. Well, I'll step back a bit. The child core measure set, we worked collaboratively with ARC on, and it included a scan of the measures that were in existence because part of our CHIPR legislation required measures to be included in the core set that were in existence, so there was that limitation. And then the next phase of that was to identify the gap areas, and we funded centers of excellence. I believe there were 10 or so with grant funding for 4 years. That funding is coming to an end soon. Some of the, there's some rollover of funds and things like that, but I think in the next couple of years that funding will be ended. So that was the new measure development piece to fulfill gap areas within the course, the child core set. But as a part of that, then there is a call for measures, and there is a committee that reviews the measures, looks at the typical things, relevance, importance, in those areas, and then make a recommendation to the secretary for inclusion of measures in the core set. That process is evolving now that we have the adult core set measures, which followed a similar process to some degree, except we didn't work with ARC, and we're working more closely with the contracting vehicle that we have at CMS through the Medicare program, and working with NQF. So this week, in fact, on Thursday and Friday, there's a public meeting that will talk about the adult core measure set experience from states. And then, again, a discussion of gap areas. Public comment will be allowed for that will, or states, not states, but individuals can make recommendations for additional measures to be included in the core set. So it's that kind of process. It's a vetting. It's going through a body. I think the child core measure piece may be folded into that same process pretty soon, but I can't say about that specifically yet. But so essentially that's the process. So there's an open call, measures are submitted, the committee reviews, it aligns it with gap areas and the experiences of states. And just recognize that the measure set have to be relevant for reporting at a state level. So if there's a hospital measure, it has to be appropriately aggregated and rolled up to report at the state.
So there are opportunities to propose
Absolutely.
Or suggest ideas relative to gaps. There are opportunities to think about core measures, perhaps that were utilized in certain areas,
Right.
And that there's evidence for that could be expanded to the state level.
Yes, yes.
And then, so my other question, which is a little more practical, is can we go on the website and find that, or how do we do that so we can find that easily?
So the process, I should know this, is it on our website? On Medicaid.gov, there should be information about our performance measures. And so you go in, again, in Medicaid.gov, quality of care, and there's going to be a subheading about performance measurements. Because the adult core measures are going through a process that's run by the National Quality Forum, it's available on the website. So what you need to do is register today. If you want to go to the meeting on Thursday and Friday and make a public comment, there is that opportunity to do so. But that's review of the core set. There's also this tension that I hear about whether or not breastfeeding fits into the child or the adult.
ARC would argue that there's benefits for both.
Exactly. And so the way I look at it is, you just try for wherever you can, knowing that eventually I think our sets might merge into just a Medicaid core set. I mean, the reason it started as these individual silos is because one was funded by CHIPRA, the other was funded by the Affordable Care Act. And I think it makes sense for us eventually to just kind of merge the process. I can't speak to what that timeline would be, but I've recommended to others that a breastfeeding measure could fit into the adult set.
And when you say register, you mean the National Quality Forum?
Yes, so if you go to the National Quality Forum page and look for Medicaid adult, what's it, map, measures, the Medicaid map, just put in Medicaid map and the information will come up, and so you just register.
Thank you very much.
Sure.
That question is really the generic question that I want to ask both of you, because you both work with mega agencies that have a very long list of priorities, and we're trying to get you to get breastfeeding on that list or further up on that list. And so, first of all, having you here is an important part of that process, and we really appreciate it. How can we help you to move breastfeeding higher up on the list, or even in very specific things like get it into a data set, get it into a survey? What's the process for each of you to help us and all of the agencies represented here do that?
Well, as I mentioned earlier, one of the things to do is be aware of opportunities for public public comment. And know that you also have, and I'm more than happy to say this, know that you have friends on the inside in some respects. So, you see something in particular that strikes you as an important issue and you have an opportunity for public comment, you make the public comment, but flag it for people like me and drop me an email. I'm easy to find and say, hey, I saw this, just wanted to make you aware of this particular issue. And also when you do that, send supporting information as well, something that I can look at and say, okay, this actually makes good sense. And sometimes we can say something to the right people or make sure that it's at least flagged. We can't make decisions. We can't advocate particularly for things in some respects, but there are certain things that we can certainly make sure get flagged because we have, when push comes to shove, we work for the American public, so we do your
That's
bidding.
us.
Exactly. So again, if you see things that need to come to our attention, feel free to reach out to folks. I say reach out to folks directly.
I'd just like to add, recognizing what you said about priority areas in the list. One of the things that we have tried to do is keep our lists parsimonious. That's been a very favorite word within our group. Certainly there are numerous things and issues and concerns that could be addressed in a core set. But we have to recognize that we're asking for states who are already constrained in many ways to do something else. And so one of the other things that we're also considering as we develop new measures, so as I mentioned, those centers of excellence have been working on measures. All of those measures are not going to be in our core sets.
Those are centers of excellence on what?
So they're for new measure development related to child health. So that if you go to the ARC website, there's a description about the process that we undertook to identify the initial core set for child measures and then for updating the measures on an annual basis. And so the Centers of Excellence was tasked with fulfilling the gap areas, so coming up with new measures for those gap areas. They certainly all cannot fit into a core set because we won't have parsimony. And we will hear about it, and things are burdensome. But we're thinking about ways to put out those measures and similar measures into this arena where a state, for our purposes, states can use for their quality improvement projects and purposes, because we certainly can't accept or make that kind of request, where there's like a laundry list, if you will, of measures addressing any number of conditions or ways to measure it and all of that. And so that's one of the things that we are working on is how to put these new measures, measures that we think are good, into the public arena for use.
Would it be helpful for all of us in whatever state we sit to be communicating with the state Medicaid agencies and communicating that we know these core measures are being reviewed right now and have input at that level?
Well, the states themselves, so there's representatives from states that sit on the vetting, the body that vets the measures. I don't necessarily think that would be the best way. I think if you bring the issue itself to, so if you want to increase the rates of breastfeeding and you bring that issue to Medicaid, I think you'd have better luck there than to try to advocate for a measure in our core set through the state. I think, again, we can provide the menu of measures that could be used for quality improvement purposes, that could be used to monitor and monitor outcomes and activity. But I don't think that that's going to be your best way. I'm trying to think of other. I think it goes back to what Dr. Askew said in terms of public comment opportunities, because they're really public, like anyone can come. The Federal Register often includes the information about when these meetings are held, and as I mentioned to the previous person with question, there should be some information about the process on our website. So if it's not on our website, because NQF has been designated for the purposes of the adult core measures, at least at this point, for that review and vetting process, information will continue to be on that site as well.
That's great. Thank you. Well, thank Marsha Lily Blanton for lending you to us.
Thank you.